Hi, this is Dr. Bhargava, and this is a new body imaging case series. This is our first patient. They presented with right lower quadrant abdominal pain, and a CT of the abdomen and pelvis was acquired. And so we were suspecting acute appendicitis, but it turns out that they have diverticulitis involving their cecum, which shows multiple diverticuli and one inflamed diverticulum right here. So diverticuli are generally more common in distal colon, descending colon, and sigmoid. They are seen in older people, I would say 40 years plus, although we are starting to see them in younger people as well. And when these get inflamed, it's a frequent cause of abdominal pain that brings patients to the ER. Usually it's a left lower quadrant abdominal pain, and CT is performed to make the diagnosis of diverticulitis and look for any complications such as perforation, abscess formation, or fistulization. Some patients may have pancolonic diverticulosis, and in such patients there can be diverticuli in the entire colon, and if they get inflamed outside of the distal colon, then they can mimic things like acute appendicitis or acute cholecystitis. Here's our next patient, and we performed a CT of the abdomen and pelvis. And on these images, I'm trying to show you different parts of a penile prosthesis. So at this level in the pelvis, we see the cylinders of the penile prosthesis or implant. This is the reservoir, which is usually in the intraperitoneal compartment in the left or right lower quadrant. And then there's a part that is in the scrotum, and we see the reservoir here, part of the cylinders here, and the cylinders here. So sometimes we perform CTs to evaluate devices, and in such situation, it's very important to know what are the parts of the devices, what do they look like on CT, and what complications to expect. So this is a graphic from the internet, Cleveland Clinic, and so this is showing the different parts of a inflatable penile implant. So when the reservoir is full, the cylinders are flaccid. This is the pump, which is in the scrotum. And when the reservoir is empty, we see that the cylinders lead to an erect penis, and the pump is adjacent to the release valve. So those are the parts of the inflatable penile implant that we evaluate on imaging to look for whether they have displaced from their normal location or if there is any break in the tubings or catheters that are a part of the implant. This is our next patient, and we will start by first looking at the rotating PSMA PET image. So we see physiologic uptake in the lacrimals, salivary glands, liver, spleen, excretion from the kidneys into the bladder. We don't see any uptake in the region of the prostate. Right there. We don't see any pelvic lymph node metastases that are PSMA avid, but we do see a focus in the bone, and that corresponds to this focus in the left scapula. There is it's hard to see any bony changes in the bone windows that are pathologic. And so this patient has history of prostate cancer, and they've had prior prostatectomy, and they presented with rising PSA. It was 73.3 at the time of this PET CT. So let's look at their history. This is their bone scan some time ago, where we do not see any evidence of metastatic disease. Then they presented with rising PSA, and there was this focus in the left scapula. And the history at that time was diagnosed 5 years ago, followed by prostatectomy and radiation therapy. PSA at the time of diagnosis was 22. At the time of this first whole body bone scan that showed the abnormality, their PSA was 57. That was 4 months ago, 4 months before the PET CT that I showed you. So the PET CT shows that this focus in the left scapula is enlarging. And so this is definitely a solitary bone metastasis in the scapula, something which is very rare or not very commonly seen. And so here, when we blow up the images, we find that there are some architectural changes or morphological changes in the left scapula. But when there is focal intense uptake like we saw on the PET scan, it cannot be anything else other than PSMA avid bone metastases in this patient. This is our next patient, and here I want to show you how to look for patient rotation on a chest x-ray. So we want to look for the spinous processes, and we want to look at the distance that these spinous processes are from the medial aspect of the clavicle on both sides, and whichever distance is more, that's the side that the patient is rotated towards. And it's important to know that because that changes the appearance of the lung fields and the cardiomediastinal silhouette. So the same patient we find on another chest x-ray, these are the spinous processes, and this clavicle is close, the left clavicle is closer to the line going through the spinous processes compared to the right clavicle. So the patient is rotated towards right, and you can see how the cardiomediastinal silhouette changes when the patient is rotated. So that's the first thing to look for when you're reading a chest x-ray. This is our next patient, and we have performed a FDG PET CT. Let's start by looking at the rotating image. We see physiologic distribution of the tracer in the brain, vocal cords, liver and spleen, excretion from the kidneys into the urinary bladder. And then inferior to the urinary bladder, we see this linear focus of intense uptake and a focus in the left inguinal region. And so that's the focus in the left inguinal region. Here is uptake in the focus inferior to the urinary bladder. And on their corresponding MRI, we find that there is a hypoenhancing circumferential thickening of their urethra. And it is also seen here, although not very clearly seen. This patient was diagnosed with a squamous cell urethral cancer, a female patient, and was sent for staging for their urethral squamous cell carcinoma. And we find that the tumor was hypermetabolic and there was metastatic disease in the left inguinal lymph node. These are some more images from the same patient. So here on a blown up T1 fat saturated contrast enhanced image, we find circumferential thickening of the urethra from the tumor. And on this DWI image, we find high signal, low signal on ADC, confirming restricted diffusion in this tumor. So the patient was treated. And this is a follow-up PET CT where we see that the hypermetabolism in the urethra has resolved and the focal hypermetabolism seen in the inguinal lymph node has also resolved. Here's our next patient. We performed a CT of the abdomen and pelvis for abdominal pain. And here the finding is abnormal soft tissue density in the retroperitoneal space in the para-aortic region. So right here, best seen on the coronal image, and also seen right here on the axial image. Finding like this is consistent with retroperitoneal fibrosis. This is our next patient. They were diagnosed with neuroendocrine tumor, and the primary was removed surgically, and they presented for a follow-up. The findings are very hard to see on this contrast enhanced CT, but there are enhancing foci that suggest recurrent disease. And so the point on this case is to appreciate the contrast that we see on a dotatate PET CT in these patients compared to a contrast enhanced CT. So here is a rotating image from their dotatate PET CT showing physiologic uptake in the pituitary, mild uptake in the salivary glands, some uptake in the multinodular goiter, and then liver, spleen, kidneys, and urinary bladder. And the tumor is seen right here in the pelvis as foci of increased uptake, consistent with metastatic disease. And these are PET CT scans from two different time points. These are slow-growing tumors, and we were monitoring them. The difference between the time gap between the two scans is 5 years. Patient was asymptomatic, and the surveillance imaging PET CT was stable. Here is our next patient, and we have performed a CT of the chest, and we find several findings related to sickle cell disease. There is diffuse intense calcification in the spleen. This is also called autosplenectomy, and the vertebral bodies show characteristic fish mouth appearance from sickle cell disease, and also the trabeculae are hyperdense compared to what we see in normal patients. These patients also develop hyperdense gallstones, and that's another finding related to their sickle cell disease. In this next patient, we were looking for esophageal perforation. And a CT esophagogram was performed, and that incidentally showed a small hiatal hernia with contrast inside on this axial and coronal images. This is our next patient, and this patient underwent a PSMA PET CT. They were presenting with rising PSA, and on this rotating image we find that there is multifocal intense uptake in the bones consistent with multifocal metastatic disease, and almost approaching a superscan pattern where there is minimal uptake in the soft tissues, and in a superscan we don't see any tracer excreted from the kidneys into the bladder. Here we see some uptake in the kidneys and some excretion into the bladder, and they have a Foley catheter draining the excreted radiopharmaceutical. On the right we have sagittal CT image and bone windows showing multifocal sclerosis corresponding to what we see on the PSMA PET scan, and also a sagittal image from the chest showing in the bone windows multifocal sclerotic metastasis. This is our next patient, and here there is a good correlation between the CT and plain film finding. Let's start with the plain film on the left first. There is a opacity involving the peripheral aspect of the right lung field, and this opacity corresponds to this large collection associated with pleural thickening and enhancement, and also internal air or gas also seen here. And so it's like a loculated effusion with signs of superimposed infection. So now it is called an empyema or an infected pleural effusion. Here is our next patient. They underwent a whole body bone scan. So we have acquired anterior and posterior whole body images to look for osteoblastic bone metastases. The only finding we see here is this diffuse increased uptake in the right proximal femur or femur head, and correlating it with the CT, we find that there are extensive degenerative changes. There is asymmetric joint space narrowing, there is subchondral sclerosis, and cystic changes consistent with severe DJD. So remember that degenerative changes can lead to increased uptake on a bone scan and not call this osteoblastic bone metastasis. Here is our next patient, and this is a scout image from their CT of the abdomen and pelvis. The opacity seen here in the right side of the abdomen is in the pattern of the major calyces and collecting system of the right kidney. There is a focus that corresponds to the left kidney also. So there is stone formation. Let's take a look at the cross-sectional images. This is the staghorn calculus that we see in the bone windows, and these calculi take the shape of the collecting system, major and minor calyces, also seen here in the soft tissue window. The other interesting finding is the hypodensity that extends from it into the renal parenchyma. That finding is characteristic of XGP or xanthogranulomatous pyelonephritis. These patients typically present with signs of infection such as fever and chills and flank pain and tenderness. This is our next patient. These are two different images from their two different CT scans. Initially, they presented with this large right-sided fat-containing inguinal hernia. We see the fat extending into the scrotum, and after this was treated surgically, they presented with fever, chills, and pain. and on their CT at the same level, coronal image shows this collection with rim enhancement extending from the site of the post-surgical changes into the scrotum. So this would be a seroma or an abscess. Here's our next patient. And so this patient underwent a CT of the abdomen and pelvis, and the finding was unfortunately incidental. Their axial image at the level of the IVC, we find that there is a filling defect or a photopenic or a hypoattenuation in the IVC, and on the coronal we find that there is this clot that extends up to that level into the IVC, and it starts from somewhere in the right lower extremity, and we see some of that here also. So this is a good example of how DVT would look incidentally on a CT of the abdomen and pelvis as a filling defect in a vein that is expanded compared to the vein on the other side if you're looking at the extremities. And there may be some inflammatory changes around them. There may be some asymmetric soft tissue swelling of that extremity like we see here, although the other side is not completely in the field of view. And so it's important to pay attention to vessels and the opacification of the vessels and know what phase or in which phase the scan was acquired, and if it is an extremity, like I said, compare it to the other side to see if there is any asymmetry. So DVT on a CT would cause dilation or expansion of the vein, and then a filling defect inside, which is a clot. Here is our next patient, and these are two different studies. We were reading the scan on the left where there is a double J ureteric stent. The proximal end in the left renal collecting system is okay, although there is some hydronephrosis compared to the other side, and there is some fat stranding around the collecting system. The distal end shows, especially in the bone windows, the concretions around the distal end of the pigtail. The distal end of the pigtail is where there are holes for the urine to come out into the bladder, and when concretions develop, those holes are blocked and the catheter malfunctions or is not functional anymore, and so there will be upstream hydronephrosis that we see here. And so compare it to the prior scan when the catheter was placed, the proximal end looks okay, there is no hydronephrosis, and the distal end looks okay also. So make sure when there is something hyperdense that you're evaluating on CT, you use the right window, and a lot of times bone window is a good place to start, and then you can maneuver to the settings that best show the finding. This is our next patient, and here the finding is seen right here, a sliver of air. It's in between the diaphragm and the liver. So is this real pneumothorax, or could this be an artifact? And so the answer is, in their CT, we find that several loops of bowel, colon especially, because we see the haustra, are in front of the liver. And so here's the diaphragm, and we see the liver posteriorly right there, and in front of it we see several loops of the diaphragm. This is also called chylidity sign or chylidity sign, however you want to call it, where the loops of colon interpose between the diaphragm and the liver, and that can give rise to a pseudoperitoneum mimic on plain films. This is our next patient. They underwent a DEXA scan, and we have two images, lumbar spine and the hip. We find that there has been a significant decrease compared to their study few years before the current study. And the same thing here on the spine, significant decrease in bone mineral density. When we look at the spine, we find that L2 vertebral body is vertically narrow compared to the vertebra above and below. And so it's important to recognize insufficiency fractures on these images. So L2 has a compression deformity, and this is a correlation with their plain films, where on this lateral view we find that the vertebra is compressed, and we see that finding also right here on the frontal projection. Here's our next patient, and they drew the region of interest incorrectly between the current and the prior DEXA of the spine. And so here this vertebral body is labeled L4, but here a vertebral body above that is labeled L4. And so something like this, if you come across it, let the technologist know to reprocess it, because they've chosen the region of interest incorrectly, because of which the comparison is inaccurate with the prior study. Another similar finding in a patient where look at the region of interest in the right femoral neck and compare it to the prior. They don't look the same, and that could be the reason why there is such a significant decrease in bone mineral density between the two studies. And so reviewing the region of interest is very important for the current study and also the prior study to make sure that we are comparing apples to apples. This is another DEXA where we don't want to report L1 through L4 in this patient because they've had posterior fixation and metal. And so in this patient, we only want to report L1 through L3 and exclude the L4 vertebral body with the metal artifacts. Here is another patient. I'm showing two images. One is a DWI image from their MRI of the abdomen, and other is the coronal T2 weighted image. And I want you to appreciate multifocal metastatic disease in the liver. There are innumerable foci of high signal, and they are seen much clearly compared to this coronal T2 weighted image, where the high signal intensity on T2 is not very well seen compared to the high signal on DWI. So DWI is definitely more sensitive for looking at smaller mets to the liver. Here's our next patient, a pediatric patient who presented with right lower quadrant abdominal pain. And this is one of those rare situations where we picked up acute appendicitis on ultrasound. And so we see on the single image with a color Doppler box on it, a hypoechoic tubular blind-ended focus in the right lower quadrant, and a pendicolith with shadowing, and there is mural hyperemia, all consistent with acute appendicitis on ultrasound. Thank you for watching.